Pleasure of introducing our last keynote speaker, Dr. Chethan Bachireddy. He's an associate professor at Baylor College of Medicine and University of Houston College of Medicine. He is a mission-driven physician leader with a track record of partnering across sectors and disciplines to deliver equitable, high-quality healthcare at scale. Most recently, he served as the Chief Health Officer at Harris Health, which is the fourth largest public healthcare system in the U.S., and the Chief Medical Officer at Virginia Medicaid, where he led the efforts related to COVID-19, digital health, and overdose crisis, maternal health, and access to care. And I know our RICE organizers have saved the best for last, so I cannot wait to hear us talk this afternoon. Thank you.
All right, thank you so much. I don't know about best for last, but certainly I'm the guy that will help you ride out the storm outside, so you're welcome. All right, so I wanted to start my slide here because I think many folks can empathize. So before we get really started, just a show of hands, how many people have encountered this at some point in their lives? Raise your hands, keep them up. All right. For those of you who don't have your hands raised, you will encounter this. But the story here and the point here is that if you've raised your hand or if this sounds familiar, you're certainly in the right place, in the right conference. And so just want to thank Rebecca and the rest of the team for putting this conference together. It's been a fantastic day to be here. I know you guys, there was a number of amazing sessions yesterday as well. It's just been really extraordinary, the abstracts, everything. So just a round of applause to the conference organizers, the abstract winners, please. Thank you. All right. And so after speaking with Rebecca, I actually changed the title of my talk. And I thought it would be really relevant to this audience, to this group of change makers from different disciplines, to talk about the tools of transformation and really technology, trust, and policy, and how that can ultimately drive better health. As you heard in my intro, I'm a physician, and I've had the good fortune of working across sectors to impact health in different ways, starting in global HIV, and then most recently in the safety net and at Medicaid. I wanted to start here because, many of us who've been following the news, whether we want to or not, understand that we face a crisis, and we also face a paradox. And this paradox, I think, is really, challenging a lot of us in the room, that the U.S. has the lowest life expectancy among its peer nations, and yet it spends by far the most when we talk about healthcare. And if you look closely, you can see that the United States, if you live in the United States, life expectancy is about 78 years. That's the average. Compared to other high-income nations, it's about 82 years, so a 4-year gap. And then you have countries like Japan and Switzerland that are even higher at 84 years. When you look at the health spending, you see we are by far number one at $13,000, double what the UK, double what Canada, double what Japan is spending each and every year on healthcare. And to top it off, we're the only nation among the nations listed here that doesn't offer some sort of guarantee, some sort of universal health coverage. And when we look closer to home, when we look at Houston and Harris County, the disparities, the data around life expectancy become a bit more dire. And so this map, again, Harris County and Houston, you see that your zip code is more impactful than your genetic code. This is something we heard from some of the speakers earlier today, and this map really drives that home at the local level, right where we're standing. And you can actually pinpoint us, where we are, pretty close to Bel Air, where a baby born today can expect to live to a respectable 87 years. That's pretty good, right? That we're getting to Japan, Switzerland-like levels. But then if you go 10 miles north of here to Sadegast, a baby born today can expect to live to 66 years. That's a 21-year gap in life expectancy. I mean, I don't think I need to say much more other than that gap in life expectancy, tells the story, right? It tells the story about how and why we are all here, which is to bring innovations to communities and to zip codes, regardless of where people live. Regardless of the color of skin or their income. And so, these are the questions that have driven me throughout my career. And what you see here is the spectrum of translational research. I think many of you will be familiar with it. Actually, we've been talking about it a lot today in different ways. When we talk about new devices, when we talk about new discoveries, we're talking about the bench. We're talking about kind of T1, where we're starting to figure out how do we move from bench to bedside. Does this invention work? And then we start to move to patients. Does it really benefit them? And we get a little further on in the phase 2, phase 3 clinical trials. And then we start to get to practice. Can we deliver it reliably? Can we deliver it with fidelity? That starts to be T3. And then T4 is, does it improve the health of the population? And so my work has mostly been at T3 and T4. And we'll be talking really about these questions and how we might start to answer them. And I think the other facet of this spectrum that makes it so meaningful is that it's not just about walking through this life cycle. There's a time element as well. And there's an equity element that we saw in some of the maps. I think what some of you may know is that on average, it takes about 17 years for proven intervention with evidence to reach just half of the population, right? Why is that the case? And certainly there's a whole group of folks who are least likely to get that innovation, right? The other half, so to speak. And so the question driving many of us today that we've been talking about today, and for those of you who were yesterday that we've been talking about, is how do we close the gap between what we know, between the challenges that we see, the innovations we're able to create, and what we do, between what people receive, right? Between science, evidence, action, and ultimately impact. The first story I'm going to tell today is the story of technology, and really the promise of technology. And when I talk about technology here, I'm really talking about technology platforms. I'm talking about, your Facebooks and your Twitter, now X, your other social media platforms that at a click of a button, we can communicate at scale, right? We have information and misinformation that can travel, at the speed of a click. And we see that each and every day, the good and the bad of that. And so the question then becomes, how do we unlock the promise of this for the betterment of society? How do we unlock the promise of this for improving health across a population? My colleagues and I were wrestling with this very question, trying to figure out how do we tap into this technology, into this platform to make a difference on health. And so we decided to test this in the realm of physical activity. And we picked physical activity for a lot of reasons, but one of them is that we think it's a bit, it's got a marketing problem, it's got a PR problem. And so it accounts for 9% of global mortality, domestic mortality as well, on par with obesity and smoking, and yet just receives a lot less attention. In a recent study among women over the age of 62, the finding was that if they were exercising 4,000 steps a day, 3 or more times a week, then they would cut their mortality by 40%. And in other studies, they found that if you take the group of inactive folks over 50 and made them active, you would add years of life expectancy, upwards of 3-4 years of life expectancy. And so physical activity, the benefits are really clear. And yet less than half of US adults engage in recommended physical activity. So this is a really classic and important problem to figure out, how do we close the gap between what we know and what we do? As we were thinking through our product considerations, as we were thinking through our intervention, we came up with a couple of design principles that we wanted to make sure that we hit. The first was that the intervention, it had to be clinically relevant, had to be measurable, scalable, low cost, focus on the underserved. And then equally importantly, we want to get to a place where we were not only engendering behavior change during the intervention, but afterwards. We wanted to create a habit. And so we focused on those with heart disease or at risk for heart disease. So 50% of our population had heart disease. The other 50% was at risk. We wanted to make sure it was measurable. So we looked at step count and we gave people Fitbits to help them measure their step count and made sure it was scalable and low cost by connecting the Fitbits to their cell phone, and the whole entire intervention was text message based. And we focused it on the underserved. We focused it on low-income populations in West Philadelphia, in part because of the equity challenge, but also because many low-income folks in West Philadelphia on Medicaid or uninsured simply have fewer options for physical activity than their wealthier neighbors. And then the last was a focus on habit formation. And so we looked to the literature on behavioral economics, on behavioral science, and came up with a few themes that we wanted to use to design the intervention on. The first was the intervention needed to be fun. It needed to be fun to make the habit stick. The second was that in addition to being fun, it had to be easy. It had to be extremely easy. It had to be attractive. It had to be salient, meaning people didn't have to fuddle around to figure out how do I engage in this game, and it had to be timely. The feedback we were giving had to be timely. And so we created a game, a behaviorally informed mobile game. A bit of a mouthful there, but really the way it worked was quite simple for a game. So the first is everybody would get a Fitbit, and of course they would have their cell phone, and they would receive 70 points each week. And then, they would receive a daily text message with the prior day's step goal. If they met the step goal, fantastic. They kept their points. But if they didn't, they lost 10 points. And this here is, really leveraging the principle of loss aversion. Many of you have heard of this, which is that we as humans, we count losses at a much higher level than we count gains. So we feel the loss of 10 points more than we feel a gain in 10 points. And so if they didn't meet their daily goal, you lost 10 points. If by the end of the week you had 40 or more points, you moved up to a level. You went from gold to platinum. Or if you didn't have those points, you went from gold to silver. And then we came to goal setting. How do we set goals for folks? Physical activity is important. Yes, we want to make it fun, but how do we set goals? And we found that no one really knew the answer to that question. Everybody was just kind of making it up. And so we thought, okay, there are some ways we could do this. We could have people choose their own goals and leverage intrinsic motivation. We could assign them goals and saying, hey, we know how much you should be walking. Here's how much you should be walking. Here's your goal. We could ask people to meet that goal tomorrow, or we could ask them to meet it over the course of 8 weeks, something called the goal gradient effect. We didn't know the answer to these questions, so we randomized people to 4 different intervention groups. And the results were really exciting. What you see at the very bottom is the control group. So in the control group, folks received, yes, they had a Fitbit, and they got feedback. And even in that group, folks did pretty well. I don't know if you can see it up there, but essentially they went from around 5,600 steps a day to close to 6,400 steps. That's in the control group without the game. But once they had the game, they started to take more steps. And I think really excitingly is we saw that those who chose their own goals and were asked to start meeting them immediately, there's something about it that tapped into their intrinsic motivation. And they had a 22% increase over the control in terms of steps. Now, these are folks with heart disease or at high risk. These are folks who don't have opportunities for physical activity in West Philadelphia, and yet they were finding ways to increase their physical activity by quite a bit, by what I would argue is clinically meaningful for this population. And we followed them not just during the intervention, but afterwards. We turned off the game and we kept the Fitbits on. And what we found was that the behavior was actually sustained after the intervention. And so this was really exciting and really compelling and eminently ready for scale. We had tested it among a handful of patients, 500 patients through the University of Pennsylvania system. And we were able to scale it across the system because we had created the infrastructure to allow it to scale. The second story I'm going to talk about, and is there a clicker here? You guys can feel I want to leave this podium. The second thing I want to talk about is about trust. And, giving this talk, let's say in 2019, would be different than giving it in 2025 because we've all been through a seismic shock of a pandemic that has threatened the very trust that we all have, that the public has in their doctors and in the health system more broadly. In one study that was published in JAMA, they basically did surveys of the US public. And what they found was that in 2020, at the start of the pandemic, high trust in physicians and the health system was at 71%. Not bad. And then each successive wave, they tested every 6 months, it went lower and lower until 2024 when trust was around 40%. So it had declined from 2020, it's 71%, to 40% by 2024. So in a few short years, we had a steep decline in trust from 70 to 40%. And so this is now more important than ever. And what I'm going to talk about in this story is how we at Harris Health create a program to build trust through community health workers to reduce emergency care and improve health. And the best way to talk about this story is through one of our patients, Mrs. J. She's 56, primarily Spanish speaking, uncontrolled diabetes. She was seen by a physician 20 years ago. 20 years ago. That's when she was diagnosed with diabetes. And she didn't follow up. And there's a whole host of reasons she didn't follow up. She was nervous about the diabetes. She didn't quite understand it. She felt intimidated by healthcare. She didn't always have access to healthcare. Lots of reasons, right? Lots of reasons. And yet, 20 years, her diabetes progressed. She didn't quite understand what it meant to have a diabetic-friendly diet. And she certainly wasn't taking medications for diabetes. So it got worse and worse to the point where she started to lose her vision. And at that point, she realized it was an emergency and she had to do something about it. She didn't really know if it was from diabetes or not, but she had to go to the emergency department. Makes a lot of sense. That's what I would do if I started to lose my vision as well. So she went to the emergency department at Ben Taub. And the emergency docs there, they did what they could. They said, okay, lady with vision loss, what's going on? They saw her A1C of 12.8, which is extremely high. And they put two and two together and said, okay, this is likely due to her diabetes. She needs to engage with primary care. They maybe wrote a prescription and sent her on her way. Fortunately, we had a CHW program, a community health worker program, and a community health worker followed up with her the next day and said, okay, Mrs. J, we saw that you're in the emergency department and need to be engaged in care. How can we help? And she said, I would love to be part of this program, but I can't pay. And my English is not very good. And they said, don't worry. No te preocupas. They were like, don't worry. I speak Spanish and I'm a community health worker and we can help you out. And this is free for you. And so the community health worker visited Miss J at her home, taught her about diabetes in her native language, helped her enroll in Harris Health Charity Care, made sure she scheduled her first primary care appointment. And then she took the next step, which was to accompany her to that primary care appointment, which was to make sure that there was a Spanish translator there at that appointment because the doctor didn't speak Spanish, to make sure that she got to meet the diabetes team there, the clinical pharmacist, the nurse diabetes educator, right? Not all clinics have this, but we have it at Harris Health, which is great. The dietitian. So she met all of those folks. And over the intervening months, her A1C improved to 8.7%. Along the way, we learned that her vision, yes, the sort of almost complete blindness that she faced was largely due to diabetes, but she also needed glasses, right? She also needed glasses. So the CHW helped her get glasses. The CHW helped her get food as well. And so this is really a success story. And the person at the middle of the success story is a community health worker, is a person who bridges the gap between community and clinic, between the patient and the often confusing, complex, expensive healthcare system. That's what a community health worker does. And we've heard community health workers talked about quite a bit during this conference. And I think with good reason, because when you have community health worker-led programs, when you shift from acute care to outpatient care, primary care, when you shift from impersonal care to relationship-based care, you get really amazing results. And in our program, we care for 300 to 400 folks a year. This was the latest in terms of results over the past year. And we saw that primary care visits went up 55%. Great. They should. That's what we want. A1C went down. We also want that by 2.7 points. And emergency room visits went down 30%. And hospital visits went down by 82%. Right? 82%. And this is not the only program with results like this. There are plenty of other programs that have had profound results that have been replicated across systems in the US and abroad. And someone mentioned that community health workers are more prevalent in resource-poor settings globally. That's true, they are. And they should be prevalent here in the US as well. The last story I'm going to tell is around policy. And this is the role that policy has been mentioned a few times as being important. We have to think about the system. How do we scale? So this story is about Medicaid and payment policy and the role that Medicaid policy can have in incentivizing adoption, really accelerate adoption of life-saving, of evidence-based therapies. And and I'll particularly talk about the overdose crisis. And so this chart brings a lot of memories for me because it was the first chart I saw when I started at Virginia Medicaid as a medical officer there. And what I saw was essentially that there was a crisis in the state of Virginia. And that overdose deaths had doubled, more than doubled over the past 10 years. And there weren't really signs that things were going to get much better. I knew, even in my first days at Medicaid, that Medicaid had a big role to play. 40% of those with opioid use disorder are enrolled in Medicaid. That's a lot. That's a lot. And so as Medicaid goes, so go other payers as well. And so Medicaid is able to lead and influence the way other payers set policy. I learned that a little bit later. But Medicaid has a huge, huge role to play in the overdose crisis in setting policy. The other thing I knew was that overdose deaths were largely driven by opioids. They still are today. And that we had really effective medications for opioid use disorder in the form of methadone, buprenorphine, naltrexone. Medications that have been around for decades. Methadone's been around for 50 years. Buprenorphine's been around for 20 years. Naltrexone, even longer. And so these same medications, they reduce the risk of death by 50% at least. And it's higher among certain high-risk populations. And yet just 22% of folks receive them every year. And when you dig into the data, numbers are actually a little bit worse because of those 22%, about a quarter stay on past 6 months. And they should be on much longer, right? And so a fraction of folks were receiving this medication. So we knew we had to do something. Fortunately, there was political will, and that really matters when you're trying to make change in policy. The governor, Republican and Democrat legislators in Virginia cared about this. It impacted them. It impacted urban Virginia and rural Virginia. And so they agreed that we needed to overhaul the Medicaid program. And so we made a couple of changes from 2017 to 2022. The first is that we introduced a new addiction benefit. Prior to that, coverage was limited, it was confusing, reimbursement was really low. So we introduced an addiction benefit, integrated it with physical and behavioral health and the medication benefit. We increased reimbursement from Medicaid levels to Medicare to even commercial rates. We incentivize team-based care, and you'll see some themes here about the importance of team-based care. When we started, there were no clinics that offered team-based care. And by that, I mean care where you have, for a population, the relevant specialties. So for addiction, it would be an addictionologist, it would be a behavioral health practitioner, it could be a therapist, and it would be a physical medicine doctor, primary care doc, and it would be a care coordinator at the very least. And so we incentivize that. And we increased that from essentially 0 to over 200 in a very short period of time. People wanted to do this. They really wanted to do this. They just didn't have the funding to be able to do this, right? That's how you get from 0 to 200 in a short period of time. We expanded coverage. We expanded Medicaid. We're the 32nd state to expand Medicaid to 400,000 people overnight, and it made a difference. It made a big difference. We removed barriers to medication. Prior to this, a lot of states actually put prior authorizations on these life-saving medications. I think largely because of stigma, not because of the evidence. And so when we removed some of those barriers, that alone was really impactful. And we supported folks during high-risk transitions. The epidemiology we had showed us that when folks leave jail or prison, when they leave the emergency department, when they leave residential treatment, they're at especially high risk for not engaging in care and for overdose. And so we made it a point to fund care coordination and peer supports for those transitions of care. And when we started to do all of those things, and to be clear, this is close to 40 or 50 policies. It was a lot. It was not, I'm kind of summarizing here, but it was a lot over the course of a number of years. The big ones were Medicaid expansion, certainly, but there's a lot of policies to create the impact that we did. And what we found was really quite extraordinary. And we found that in 2016, there were about 6,200 folks who were receiving medications for opioid use disorder, right? Buprenorphine, methadone, naltrexone. The addiction benefit increased that to 9,000 and 12,000, and then Medicaid expansion doubled that. And it was only a matter of time that the rest of the policies really played a role in increasing it to 43,000. And it's been stable since then. But That's a 5 to 6x increase over a very short period of time, right? People wanted to do this. There was latent capacity throughout the state. It was simply that folks were not enrolled in Medicaid. And so once we created the parameters, once we set the table for a more successful, more coherent response to the overdose crisis, people stepped up. And it was really, really incredible to be a part of this. And so this is my last slide here. And at the end of the day, we all see challenges, we all see problems in our context, but I strongly believe that there are tools and levers that we can deploy, and we've heard so much about that today and even yesterday. This is just a smattering of what I think we can do when we really focus on partnerships, when we focus on learning, and we focus on building trust. And with that, I'll leave you with a quote by Alan Kay, which is, "The best way to predict the future is to create it." And so with that, thank you so much, and I look forward to the Q&A.
Just kind of building off of Yvette's question, I feel like there are a lot of different like nonprofits, public sector organizations that do a lot of great work. But I feel like in terms of sustainability, there's a long way we can go. And I was wondering if in your experience, in Virginia or even here, if you have any insights about how coordinated care can be achieved through like having these different sectors work together.
So short, thank you for your question. It's really hard. It's really hard. And, I think it's worked in any place I've seen coordinated care work. It's always been just very local, extremely local, that coordination has happened and been successful. I'll tell you a story of, I wouldn't call it failure. I would call it not yet success. And so basically that's, it's funny to hear yourself like say something out loud. But really what happened is the state legislature in Virginia mandated the creation of a health information exchange to address this problem. They wanted to do care coordination at scale, and great, this was awesome. And I've never seen a faster, sort of mandate, really get implemented because it was basically a nonprofit was set up to then hook up all the hospitals. So they would be sending ADT feeds, admission, discharge, transfer feeds into this, central repository, this health information exchange. And it was really incredible. And it was like, oh my gosh, we've succeeded, we've done it. And I just remember sitting there and saying like, yeah, this is amazing, we should celebrate this. But I think what the legislators wanted, what everybody else wanted, was to get to coordinated care. And Virginia had reached that phase of technical ability of connecting all the hospitals in 2019. But they did it in less than a year. But essentially from 2019 to 2025, they haven't really succeeded in the coordination part. Yeah, in bits and pieces, yeah, like for this transitions of care from the emergency department for overdose, that has been reasonably successful, but at a broader scale, to do what they wanted to do, it's been very, very difficult. And so that's not a great answer to your question, other than that type of work, I believe, requires, kind of focusing on, these like kind of small success stories over time so that they kind of catch fire and scale. But then the other is you do have to set the policy table appropriately to scale, right? If you were here earlier today talking about Ethan should be everywhere, but it's not. And it's not going to get everywhere by word of mouth. It's only going to get everywhere when the policy table is set. And so yes, it'll expand, and they're working with the willing, and it's amazing, but it's a wrong pocket problem. The sort of benefits of Ethan, of avoidable emergency room visits, aren't going to the right people, essentially, who have money to proactively invest. And so that's a policy problem. It's a fixable problem. These are all fixable problems. And so I think it's both. I think it's this ground up, idea of people creating, the story and the vision and impact, as well as the policymakers saying like, oh, what can we do differently? And how do we generate will so that we can put these pieces together?
Thank you.
Thank you, Dr. Bachireddy. My name is Wei Yang. I'm actually a breast radiologist in my day job, and I really enjoyed your talk. Very fitting end to the entire conference, which I'm just looking at bringing innovations from global to local. But as you mentioned, throughout the whole day, whether it was in mobile health or rural healthcare or chronic diseases, cervical cancer, and your talk, it seemed like everyone was focusing on one theme. And that theme is building trust, messengers of trust, human connection, and that this conference has focused so well on all the good things that we've done in discoveries and innovations and in digital tools. And yet, when Lisa Hirschbaum was talking about implementation, it seems like that human glue, which is what somebody taught us, we listen to learn and learn to listen. At the end of the day, that's what I think we all want. We want to be seen, we want to be known, and we want to know that the problems that we have are being solved. So I wonder, it's actually for the entire group, as well as the students, and I was chatting with Rebecca that, for the university students, whether this is something that we can push further up the pipeline into the high schoolers and the middle schoolers, because they are the ones that live in the homes that can do bi-directional change in terms of driving a culture change for the diabetics in down south, and also in rural care, and just to infuse that whenever we are thinking of grant applications or talking to philanthropists. So just wanted to put that out there because that seemed to be one of the loudest and the most resounding messages. We're seeking that connection for greatest impact. So thank you.
That was extremely well said, by the way. Yeah, we can give her a round of applause. Yeah, that was, I don't have much more to add other than I heard that as well. And I do think a big part of it comes from the pandemic and what we all sort of lived through and experienced. And I hope it comes to a fore. Like, I hope there's a groundswell of, we need to change things to make them more human-centered, to make them more caring. And how do we start to do that? And so I think there is some visioning and, really muscular hope to sort of bring that to life over the next few years.